Lung infections still remain important in New Zealand populations. When we think about the pathology of lung infections, it's important to think about all the different organisms that might be present so we can organise the right treatment to occur. Here are some key concepts. Pneumonia is an infection of the air spaces of the lung and is caused by bacteria. In contrast, pneumonitis is an infection of the lung tissue, the walls that form the alveoli, and is mostly caused by viruses. Fungal infections are most common in debilitated and immunocompromised people and can occur in either the air spaces or invade the walls. Bacterial infections can either lead to bronchopneumonia or lobar pneumonia. At a microscopic level, both these processes are the same. At a macroscopic level, however, it's the distribution of the disease, illustrated here on the right, that lets us know the difference between broncho and lobar pneumonia. In both kinds of pneumonia, the morphologic changes will follow a classic sequence. There are 4 stages: congestion, red hepatization, grey hepatization and resolution. Since the introduction of antibiotics, this sequence is often altered, as the antibiotics treat the infection and not all the stages are seen. Let's think about what happens at the very start of a pneumonia. The first thing that happens is congestion. Here, occasional bacteria are present in the alveoli, and the air spaces fill up with clear fluid. The next thing that happens is that the fluid becomes infiltrated by neutrophils, bacteria grow, and the fibrin in the fluid starts to set. This leads to the stage called red hepatization, where the lungs look like liver. They're solid and congested. There's no air getting in those air spaces because it's full of fibrin now. As time progresses, the neutrophils release enzymes which liquefy the material in the alveolar spaces. Macrophages then come along and take up and then digest this material. Note how the alveolar walls remain intact. The reason that pneumonia can resolve is that the essential structure of the lung remains intact and all the inflammatory debris is cleared away. Bacterial pneumonia is a common cause of death in the elderly. Apart from overwhelming infection and lack of air spaces in which to respire, there are some other complications that can occur with bacterial pneumonia. The first of these is fibrosis. What happens if the material present in the alveoli isn't successfully cleared away? It then becomes organised into areas of fibrosis, and little polyps of granulation tissue grow and fill up the alveoli. Another complication is pleuritis. Initially in pneumonia, there may be a sterile effusion. This can be followed by exudative fibrin, leading to a fibrinous pleuritis. This will give the typical pleuritic pain. Healing then leads to fibrous adhesions between the visceral and parietal pleura, leading to long-standing pain and fixation of the lung within the pleural space. If infected fluid gets into the pleural space, it causes a collection of pus there, and that's called empyema. The collection is thick and sticky and usually loculates, and then these locules are followed by scarring. In the picture to the right, you can see that the left chest contains an empyema. The diaphragm is lifted up, and then there are fluid lines around the bottom edge of the airspace. Another thing that can occur is the formation of abscesses. So just like we learnt about in heart valves, there are organisms that are more aggressive than others. And if the lung is infected by a particularly aggressive organism like Staph aureus or Klebsiella pneumoniae, then it will cause destruction of the tissue and formation of an abscess, which we can recognise by a fluid level on X-ray. A type of pneumonia that we've not talked about yet is aspiration pneumonia. It occurs where the airway is not protected, such as in loss of consciousness or where there's suppression of the cough reflex, where there's difficulty swallowing or poor oral hygiene. It usually affects the dependent parts of the lung, those parts of the lung that are closest to the ground when a person's lying down. That's simply because the aspirated fluid travels downhill and affects that part of the lung. We can see the typical segments of the right and left lung illustrated in the diagram here. So it affects primarily the apical part of the lower lobe on the right and the basal part of the upper lobe on the left. Often it infects with a bronchopneumonia pattern, little spotty bits of infection. And the bacteria responsible are the indigenous flora of the upper respiratory tract. Now we'll think about viral pneumonia and contrast it to bacterial pneumonia. Viral pneumonia is commonly caused by influenza viruses, respiratory syncytial viruses, and parainfluenza viruses in children. Now we know that most patients recover from influenza, for example, and the fatalities due to viral pneumonia are usually due to superimposed bacterial infection. So what happens in these lungs with viral pneumonia? What actually happens is the viruses cause a lymphocytic infiltrate in the septi, in the alveolar septi. You can see it on the right here in the picture as those little blue dots in the septi. Notice how the air spaces remain completely clear. The inflammation, though, does compromise the function of the lung, and then any bacteria that are around can land in there and proliferate and give rise to a secondary bacterial pneumonia. Fungal infections of the lung are uncommon. They occur in immunocompromised people, particularly Pneumocystis carinii, which became most prominent during the 1980s and 90s when the AIDS epidemic first started. Aspergillus is the second most common fungus that we see in the lung. It can occur just in the airways, where it gives rise to an allergic reaction called bronchopulmonary aspergillosis. It can form fungus balls, particularly where there's been a previous cavity, for example, a resolved abscess or TB. And sometimes there can be invasive pulmonary aspergillosis, where the fungi invade into the walls of blood vessels and then can spread around the body. The slide to the right here shows Pneumocystis pneumonia. Notice how full the alveolar spaces are of this pink foamy material. In the foamy material are innumerable small fungal organisms. These are the Pneumocystis organisms. The slide to the right here shows Pneumocystis pneumonia. Notice how full the alveolar spaces are of this pink foamy material. In the foamy material are innumerable small fungal organisms. These are the Pneumocystis organisms. A type of pneumonia we've not discussed yet is lipoid pneumonia. This happens when the bronchus is blocked off and all the stuff that the lung produces, like surfactant, accumulates and fills up the air spaces. So normally this surfactant is cleared by the alveolar epithelium and via the airways and the bronchociliary action. If it builds up in the air spaces, macrophages move in and they try to digest it, however not so successfully, and we get yellow consolidation. It's frequently seen where there are lung tumours blocking the bronchi. This picture to the right shows lipoid pneumonia. You can see the intact alveolar wall and the numerous macrophages filled with the surfactant. That brings us to the end of thinking about pneumonia. It's an important disease, and understanding its pathologic basis will help you design the right treatments for your patients. You too can be a pathology superhero.